Every 40 seconds, someone in the United States has a stroke, and every minute that passes, nearly 2 million brain cells can die if blood flow isn't restored. Hi, I'm Alex, and I'm your nurse. I have spent the majority of my ICU career caring for those suffering from stroke as well as other neurological presentations. According to the CDC, approximately 800,000 strokes occur annually in the United States. About 87% are ischemic, 13% are hemorrhagic strokes. Stroke remains the leading cause of long-term disability, and stroke is the fifth leading cause of death in the United States. Someone dies approximately every 3 minutes from stroke-related causes. Most people don't even realize that there are actually different kinds of strokes, though. Understanding the difference between each of them can ultimately help us understanding recovery and then therefore treatment. So, a stroke doesn't just happen to the elderly. Every year, thousands of younger adults experience strokes too, and recognizing the symptoms quickly can completely change the outcome. So, as always, I like to dig into the anatomy and physiology first because if we can understand how something is constructed and structured, then we can understand when something goes wrong, why it goes wrong, and then how to help fix it. So, talking about the brain, because this is where strokes occur, the brain weighs only about 2% of body weight, yet it consumes approximately 20% of the body's oxygen and energy reserves. It cannot store its own, so it has to pull from the body. Because neurons have such high metabolic demands, interruption of blood flow causes injury within minutes. There's a phrase that I'm going to reiterate multiple times throughout this, but it's time is brain. And this is a phrase that we use a lot in the medical community, but it's literally every second, every minute that goes by without blood flow to the brain is risking recovery and ultimately neurological decomposition and if not death. So, blood supply. The brain is highly vascular. It needs lots of oxygen, lots of blood, lots of nutrients from that because, again, it uses 20% of the body's reserves. So it receives blood through four main arteries, which is the right internal carotid and the left internal carotid, and then also the right vertebral and the left vertebral. So you've got your brain, you've got all the different lobes, and you've got the different layers that we'll talk about in a second, but then there's tons of different vasculature and capillaries and everything that are going in there, feeding your brain because it requires so much energy. So these connect through the circle of Willis, which provides collateral circulation of one if one artery becomes narrowed or blocked. Collateral circulation can sometimes help to preserve brain tissue, but it is not always sufficient enough to prevent injury. Okay, so essentially, it's kind of like circumventing the interstate in a way using the other highways. If that one spot gets blocked off, then your brain can get blood flow from the other areas if it's in the specific location. But the idea is still that we don't want clots or blockages anywhere in any of this vascular system. So talking about the different layers, the meninges, the brain is protected by three layers. So we have the dura mater, the arachnoid mater, and the pia mater. So you might have heard maybe on a TV show or a soap opera, they'll say he has a subdural hematoma. This has got to do with the dura mater. So it's the stronger outer covering and it's the toughest layer. And so the subdural hematoma is the hematoma within that space underneath the dura mater. The arachnoid mater is the one underneath. It's that middle layer, and that actually contains the cerebrospinal fluid. And then the one under that, it's a thin layer, and it's actually directly attached to the brain, and it's called the pia mater. So why blood flow matters? Neurons rely on continuous oxygen and glucose delivery. Without blood flow within seconds, energy production starts to fall, sodium-potassium pumps begin to fail, cells depolarize, and calcium enters neurons, which essentially starts to degrade them. So excitatory neurotransmitters called glutamate are released excessively when this happens. And this triggers excitotoxicity. Essentially, it's a process that damages the surrounding neurons. So inflammation then develops, and then if circulation is not restored, the neurons will die. And this is why neurologists say time is brain. So now that we understand how the brain is structured and some of the vasculature behind it and why it's so important to maintain the blood flow in the brain and avoid clots, let's actually talk about the different types of strokes. So I wanted to cover some of the verbiage. More specifically, CVA stands for cerebrovascular accident. So many people think that CVA is a different diagnosis than a stroke, or it's a certain type of stroke, but it's really just the same thing. So cerebro means brain, vascular means blood vessels, and then accident is just the interruption or the injury to that area, right? So a CVA is essentially a stroke. It's kind of all-encompassing umbrella term. So it's a general medical term describing damage to the brain tissue caused by disruption in blood flow. So we're going to talk about the different kinds from there. So the two main kinds are ischemic stroke and a hemorrhagic stroke. So again, his ischemic stroke is 87%. It's the most common type, and this is a blood clot in the brain or a thrombus. So a clot has gone into the vasculature somehow. Maybe it's formed on its own, or it was an embolus. It got thrown. Maybe if you have a heart arrhythmia, maybe it got thrown from the heart and went into the brain and lodged in the brain, and then therefore caused the ischemic stroke. It can also be caused from severe arterial narrowing from atherosclerosis. And remember, that is the plaque buildup in the blood vessels that is then causing the narrowing and essentially the full blockage when it closes off. So blocked artery leads to reduced oxygenation because you're getting reduced blood flow, and then therefore brain tissue injury and cell death. Because again, if the blood is not getting to the brain, the oxygen is not getting perfused in there, and therefore the brain tissue is not getting the energy and the oxygen that it needs in order to function. And from there, the calcium builds up and the cells start to die, and the neurons start to die, rather. So treatment depends greatly on timing when it comes to stroke. Again, time is brain. And on timing and eligibility, and may include clot dissolving medication, such as thrombolysis, or that's what that's called, or mechanical thrombectomy, which is actually going in and removing the clot for select patients. And we'll talk about the different symptoms and how soon you want to go get seen, but I'm just talking about the differences between each stroke right now. So hemorrhagic stroke is 13%, and this occurs when a blood vessel ruptures. So it's a brain bleed, essentially. The blood leaks onto the brain. So you have a clot or you have a bleed. So the problems can include loss of downstream blood flow, increased intracranial pressure, which is really important. We want to avoid that, rather. Compression of surrounding brain tissue, and local inflammation. So a big concern with the ischemic stroke, remember that's the clot, is the decreased blood flow. That's still a concern here with hemorrhagic, but we also have the increased intracranial pressure. We don't want to put an imbalance here in the brain. It's a very sensitive environment. So if somebody comes in and has had a head trauma or they have this hemorrhagic stroke, we're very concerned about how much extra fluid, how much extra space how much extra pressure really is being applied in the brain, because your skull does not move. And so if the brain sits where it sits and then there's more in there to take up more space, it's going to apply pressure to the brain. And that's really concerning, because if it gets too high, then we can have some really severe symptoms. We'll talk about brainstem concerns towards the end, but that's one of the big concerns, is because the brain can't expand outside of the skull, it's going to go somewhere, which means it's going to go down. And if it goes down, it's going to start compressing the brainstem, and that's concerning. So we'll talk about those symptoms a little bit later, but that's the real concern here. So common causes of the hemorrhagic stroke, which is the bleed: chronic hypertension, cerebral aneurysm rupture, arteriovenous malformation, and then certain bleeding disorders or anticoagulant medications. So again, things that increase the pressure enough to cause a rupture in that vessel or additional bleeding in the brain where it shouldn't be happening. Another type of stroke that I did want to discuss, because I think it's really important, is a TIA, or transient ischemic attack. So this is kind of like it's a mini stroke essentially, and it typically resolves quickly. There's typically no permanent infarction on imaging, meaning there's not a massive bleed or clot on the imaging, but these are really concerning and they are a medical emergency because they do predict a future risk of stroke. So if you have a TIA, you'll want to get evaluated and they'll probably order scans and everything, but just because it resolves quickly doesn't mean that it's still not concerning, okay? And then I did want to mention the subdural hematoma because I already mentioned it earlier, but it's not technically a stroke. So this is an important distinction. It's usually caused by trauma to the head or to the brain. So blood collects between that dura mater layer and the brain. So because of that, you can have the increased pressure there as well. And so this can develop from torn veins in between those layers. And it's more common in anticoagulant patients or the elderly and head injury as well for a head trauma. And so this can develop very quickly, very suddenly, but it can also develop slowly over days or weeks. But different from a stroke. So remember, stroke is more, it's not so much in between the layers as much as it is closer to the brain. It could be, but stroke is typically a clot in the vessel on the brain or a brain bleed, so there is blood on the brain. So, probably the most important part of this whole episode, the signs and symptoms of a stroke, be fast signs. So it's literally the letters be fast. So BEFAST. So B stands for balance. So if you have loss of balance, and this could be maybe you're experiencing it or you see somebody else experiencing it. So it's not just like you tripped, it's you have a loss of balance and you can't regain it. And a lot of the time it's because of numbness. One side of your body will go completely numb. You can't use it. Maybe your arm can't move. You can't feel anything on your limb. Your leg, you can't stand up and you can't be stable. So therefore you lose your balance. E stands for eyes. So this would be sudden vision changes. Again, if the brain bleed happens or the clot happens, it's going to be typically on one side or the other. And the brain does this. It's a big X. So the left side of your brain controls the right side of your body and then vice versa. So if your clot or your bleed is over here on the left, then it's going to affect the right side of your body. So as a result, you'll typically feel it all over on that one side instead of just being limb specific. But again, different presentation for different people, for different bleeds, for different strokes, okay? Next would be F, which is face, so facial drooping. So again, one-sided type presentation. You'll notice drooping, particularly on the eye and particularly on the side of the mouth. And this is going to lead into another one of the signs here. So I'm not going to skip ahead yet, but essentially facial drooping, you'll notice that one side is kind of sagging and it just looks a little uneven. So A stands for arm. This kind of comes back to the numbness that I was talking about. Weakness, numbness, inability to function, maybe some loss of sensation from touching that arm. You can't move it as much as you used to. So then speech, this kind of comes back to the facial drooping I was talking about. Speech will often be slurred or incoherent, and often people will have difficulty understanding. Remember, your neurological capacity is being altered. So vision, speech, all of these different sensations are going to be different. And so the facial drooping will kind of affect some of the speech, but oftentimes speech will be slurred if they can speak at all still. Sometimes they won't be able to at all. And then time is not necessarily a symptom, but it's probably the most important part. Again, time is brain. You must get medical evaluation very quickly. I believe it's typically within 90 minutes because we want you to get seen, we want you to get evaluated, and we want to try to remove that bleed or that clot and help resolve it as quickly as we can to preserve as much brain tissue and function as possible. Because once you lose it, typically you can't get it back, but it's also really hard if you can. We'll talk about neuroplasticity in a little bit, but brain tissue, brain cells, neurons, those are not things that we want to sacrifice and lose. So, why time matters. Every minute during an untreated ischemic stroke, approximately 1.9 million neurons die. 14 billion synapses are lost. That's the connection between neurons. And the brain ages approximately 3.6 years for every hour that treatment is delayed. So, now that we've talked about all the scary stuff, how can we avoid a stroke? Is it possible to avoid a stroke? Yes and no. There are, just like with hypertension, like we talked about, there are modifiable and non-modifiable risk factors. So the modifiable ones are the ones that you can change or modify. So hypertension is going to be the largest modifiable risk factor. Again, this is going to, if your heart has increased pressure, your vasculature is going to have increased pressure, and therefore that's going to affect your brain. And we also want to help control any blood pressure, heart rhythms, or arrhythmias, because that could affect additional clots that could be thrown to the brain. So we want to make sure that we're taking the appropriate medications. If you have cardiac disorders, this will help, if you're taking your medications, reduce your stroke risk. So we want to reduce smoking. We want to have diabetes controlled as well. This goes for obesity and high cholesterol because, again, that atherosclerosis that we were talking about, that can make the blood vessels smaller because of the plaque buildup in the brain. So therefore, there's less blood flow and activity there. Then physical inactivity kind of comes to the obesity and the high cholesterol in a way, and sleep apnea as well. So all of these are kind of the same in the way of increased pressure in the body, or with the atrial fibrillation or an abnormal heart rhythm or an arrhythmia. We don't want to increase the pressure, and we want to try to maintain an open vessel and blood flow so that everything can flow and function appropriately, okay? The non-modifiable are going to be the things that we can't change. So family history, age, any genetic predisposition or conditions. It might just run in your family, but again, you can do the most that you can with the modifiable risk factors to try to reduce your risk further. So, one question I get asked a lot as a neuro ICU nurse: why does stroke recovery vary so much? Or why is his presentation so much more different than my uncle's or my other family members? I get asked this type of question a lot, and it makes sense because strokes are very variable. Just because one person had a left-sided stroke and it was ischemic doesn't mean it's going to be the same presentation as another person. Typically, it'll be fairly the same course, but the recovery is really going to be dependent on the patient and their body, but also some of these other factors I'm going to talk about here. So recovery depends upon four main things: location of the stroke, size of the stroke, time to treatment, collateral blood flow, and then also neuroplasticity. We talked about that. I mentioned it a second ago, so we'll get into that as well. So the big one is the location of the stroke. The brain is divided into specialized regions, and the different regions control different functions. So this is one of the big reasons why the stroke itself has such a different presentation, but then the recovery might be different from stroke to stroke or person to person. So if you had a stroke in the frontal lobe, this would be controlling your voluntary movement and your speech production, even your personality, your executive functioning, decision-making, things like that. And so the stroke symptoms, if there was a stroke in that area, would be weakness or difficulty speaking, personality changes potentially. It's not uncommon for stroke patients to get increased irritability. And that always really surprises the family members. They say that he's just not acting like himself, or she's really angry lately, and it doesn't make any sense. It's because this is literally altered, and so it's actually changing them. So parietal lobe is another area. If you had a stroke there, the parietal lobe processes touch, pain, temperature, spatial awareness. So these symptoms might include numbness or difficulty judging distances. You might bump into things a lot if you're actually up and moving around post-recovery. trouble coordinating movement from that as well. There's also a lot of neglect syndrome here. So difficulty recognizing one side of the body. They'll go to move their arm and they completely don't even realize that the bed rail is there and they'll just whack it. So maybe they'll have more bruises on one side than the other. If you were to have a stroke in the temporal lobe, this is responsible for memory, hearing, and language comprehension, or what we call the Wernicke's area. So stroke symptoms from the temporal lobe would include difficulty understanding speech. So if somebody is talking to the person that's affected, they will just sit there and look at you and they don't often even understand what you're trying to say. They'll have memory problems, and then from there, just confusion overall because they can't interpret the world that's coming into them. For the occipital lobe, the big one here is this controls vision. So the stroke symptoms would include mostly visual field difficulties, or such as like missing visual fields entirely. So this is one of the big symptoms in the NIH stroke scale. As an ICU nurse, when I'm going and evaluating these patients, one of the big things is we're checking your vision. So can you see when I'm in the different fields of vision? And it's very common that they'll see certain fields and then you'll move just a little bit over and they won't respond, they won't see anything. And it's really kind of trippy. Then the cerebellum, this controls your balance and your coordination, and then the fine motor movements. So again, poor coordination, difficulty walking, bumping into things, even dizziness. But moving on to the brainstem, like I mentioned a little bit earlier, this is one of the most dangerous locations. So your brainstem controls your breathing, your heart rate, your blood pressure, your consciousness, and swallowing. So all of these are very basic human functions. All of these other things are important too. Your personality, your memory, your movement, all of these things. But if you don't have the brainstem, if you don't have these other basic functions, you're not living. You're just not living. So this is why we tried to preserve the brainstem as much as possible. Large brainstem strokes can be life-threatening because they affect the body's automatic life support system. So again, if this goes, so do you. So another thing that affects recovery, the size of the stroke. So larger strokes are going to affect more neurons because they're larger. So more tissue injury will lead to greater inflammation, which leads to a greater loss of function, which then can lead to a longer recovery and rehabilitation. So small strokes may affect only a tiny region. Large vessel occlusions can damage an entire hemisphere. So the bigger that it is, the bigger the recovery. Time to treatment is also really important for recovery outcomes. This is probably the most important predictor. Every minute an ischemic, the clot stroke, remains untreated, approximately 1.9 million neurons die, 14 billion synapses are destroyed, and 12 kilometers or 7.5 miles of myelinated nerve fibers are lost. That's a lot of stuff. So essentially, imagine your brain is aging 3.6 years every single hour treatment is delayed. I mentioned all of this stuff earlier, but again, time is brain, and it's really important. We talked a little bit about the collateral blood flow earlier with the circle of Willis when we were talking about the vasculature and the blood flow in the brain. Not everyone has exactly the same blood vessel anatomy. Again, it's very intricate up in there. Some people have excellent collateral circulation, others may not. So the ones that do, these alternative arteries can temporarily supply oxygen to that affected area if there was a clot or a bleed. But others that have poorer circulation, collateral circulation their symptoms are going to present much quicker because their neurons are going to die much faster because they're not getting that extra blood flow to essentially compensate. So this explains also why two patients with similar blockages, similar locations, similar size can have completely different outcomes and therefore recovery and treatment. So one of my favorite topics is neuroplasticity. The brain is literally capable of reorganizing itself. It is so cool. Healthy neurons begin forming new neural pathways. Other regions in the brain can actually sometimes take over partially lost function. So, this is strongest immediately after a stroke, during early rehabilitation, and with repetitive practice. So, this is why we want to do the different therapies every day and be very consistent with it, because your brain can literally rewire itself. So, my nursing tips for you as we wrap up: know your blood pressure, know your cholesterol, know your blood sugar, have all of these things controlled as much as you can. I don't say this to scare you. I just say this because the unknown and the uncontrolled markers and parameters here, particularly when they are uncontrolled and outlying, right? If your blood pressure is sky high, that's going to put you at a higher risk for a stroke. If your cholesterol is uncontrolled, it's going to put you at a higher risk for blockages throughout your body, but particularly in your brain. Blood sugar, that needs to be controlled as well, because that's just going to eat away at your vessels and all your other organs if it's absolutely just raging high, right? So I always advocate for exercising regularly, eating nutritiously, and then taking your medications as your prescriber has provided them. So that would be discussed with them. I'm making no judgments or recommendations on what to take. That is to discuss with your neurologist, your cardiologist, your nephrologist, whomever. But exercise regularly. This helps keep healthy heart function and adequate blood flow. It also helps to control your metabolism and therefore your blood sugar as a result. And then all of this, of course, is going to help keep your cholesterol down so that we can ideally keep those vessels open and blockages free. Don't smoke. This is a cliche, I guess, or not even a cliche, but one that we all know. But don't smoke, because this can cause blood flow issues, hypertension, other comorbidities that essentially worsen and increase your stroke risk. Treat atrial fibrillation if diagnosed. So keeping up with your rhythm, your heart rhythm, keeping up with your anticoagulants and any other medications to help keep your heart rhythm as regular as possible, because the more irregularly your heart pumps, the more likely you are to have a clot or a blockage go in the wrong direction, i.e. to your brain. Know the fast, be fast symptoms for yourself, for your family, for everybody. And remember, time is brain. If you can identify these symptoms, you can get someone treatment sooner rather than later and likely save their life. Never ignore sudden neurological symptoms, even if they improve. My granddad was literally just telling me that he thinks he had a TIA, and I'm just now learning this. So if you are having any of these symptoms that we talked about with the be fast, the sudden weakness or the difficulty understanding speech or speaking even, these kinds of things need to be evaluated. Even if it happens for a moment and then it comes back, it's your brain signaling to you that something is up, because it could be essentially the calm before the storm, and you could have a bigger one later. And that's what we want to avoid. So, strokes don't just happen to the elderly. Every year, thousands of younger adults experience strokes too. There are modifiable factors that can be controlled in order to reduce stroke risk, and understanding how the brain works and how strokes happen can help us to recognize the symptoms. Again, time is brain. Recognizing the symptoms of a stroke quickly can completely change the outcome and the recovery. I hope this helped. If you found this interesting, please like and subscribe. It would really help. If you have any questions, you can always find me in the comments or on Instagram at Health Recoded Podcast. I will respond there. Let me know if you want me to talk about any specific topics, or if you have any questions. I'm here to help educate you, and I'll see you next week.